But we have three speakers really addressing the subject of special groups, including those with renal failure. It's really a very important group in many parts of the world. Paul Martin will address that. There are lots of contentious issues at the moment in clinical practice and in the real world. Then we move on to treatment of patients with decompensated liver cirrhosis. What's the risk-benefit ratio? A subject we touched on briefly just before this session. And again, we need some answers. It is of vital importance to many patients. And then finally, the aspects of antiviral treatment post-liver transplant. So pre-transplant will be discussed by Mark Boulier and post-transplant by Paul Coe. So I'm going to start with Paul Martin. Paul is head of liver services at the University of Miami, and amongst his other achievements, he is the current chief editor of Liver Transplantation. And he's going to talk about hepatitis C treatment in renal failure. Thanks, Paul.
Okay. Thank you very much, Jeff, and I would like to thank the organizers for giving me the opportunity to come back and participate in this very nice meeting. So as you heard, I'm going to talk about hepatitis C and renal failure, but very importantly, a lot of what's happening with antiviral therapy is going to change the way we approach renal transplant, so I'm going to touch on that also. So first of all, a little background: hepatitis C and chronic kidney disease. Hepatitis C remains highly prevalent in dialysis patients, despite efforts to limit its spread in dialysis units. And depending on which part of the world you come from, hepatitis C is more frequent in certain areas, such as developing countries, in the dialysis setting than, for instance, in Western Europe. Now, the number of aspects about the natural history of hepatitis C in patients with chronic kidney disease. Pre-kidney transplant, it's typically asymptomatic in the acute phase. In the chronic phase, patients don't mount much of a biochemical response. They have a lower ALT level than one would anticipate in somebody with chronic hepatitis C. They also have lower RNA levels, and part of that may be related to mechanical destruction of the virus by the dialysis process. They have a lowered endogenous immunological response. There are variable fibrosis rates, but very importantly, unequivocally, hepatitis C-infected dialysis patients have a higher mortality rate than patients without hepatitis C. Now, post-transplant, there are a number of issues, including higher allograft nephropathy, higher onset of diabetes mellitus, higher sepsis rates, higher cardiovascular mortality, and high rates of cirrhosis and hepatocellular carcinoma. And very importantly, hepatitis C in this setting is implicated in poorer graft and patient survivals. Now, this looks at an experience in dialysis patients, and not surprisingly, there's an excess of deaths from liver disease, but also hepatitis C in this setting is implicated in a number of other complications, including cardiovascular disease and also death from bacterial sepsis. And very importantly, as we all know, one of the surrogates for impaired hepatocellular function is a propensity to infection. Now, this looks at some of the consequences of hepatitis C following renal transplant. Obviously, there's a greater burden of liver disease, shown here on the left, but there's also evidence that hepatitis C is implicated in a number of other adverse consequences, including graft dysfunction. And very importantly, hepatitis C continues to be implicated in poorer survivals following renal transplant, as shown in this slide. And it's also implicated in graft and nephropathy, as I mentioned. Now, I've given you a lot of bad news about what hepatitis C does after renal transplant, but very importantly, there's still a survival advantage for a patient with renal failure who receives a renal transplant despite the presence of hepatitis C. Now, this is an experience from about 10 years ago, so most of these patients did not receive antiviral therapy, but very importantly, the group of hep C-infected patients who received a renal transplant did better than their the cohort who stayed on dialysis, but overall the survival rates were inferior in the hepatitis C infected patients compared to the non-infected renal transplant recipients. Now, what are our treatment options? Until very recently, patients with renal disease were regarded as poor candidates for antiviral therapy, generally due to poor tolerance of what we had available, namely interferon and ribavirin. And also interferon had been implicated in renal graft loss, so its use was felt to be contraindicated following renal transplant. Now the good news is the advent of the all-oral regimens has already drastically changed the management of hepatitis C in this population. As Dave Nelson commented earlier this afternoon, practice is now running ahead of what's coming out of the clinical trials, and there's an emerging experience with the use of oral regimens in patients with hepatitis C with various stages of renal failure. These drugs are generally safe in the presence of renal insufficiency, at least down to a GFR greater than 30 mLs per minute. There's no need for dosage adjustments in mild and moderate chronic kidney disease. These drugs are bound to serum proteins to a varying extent, which in turn may have some implications in terms of toxicity. And then finally, as I mentioned, we're now seeing a number of groups reporting their experience with oral regimens in patients with more advanced liver disease. Now, NID has never seen this before because this is from the treatment guidelines he was asked to comment on. But in essence, these are the AASLD guidelines which endorse the use of the various oral regimens down to a GFR of 30 mLs per minute. They do comment that there's limited or no information about the use of these regimens in the more severe stages of chronic kidney disease. Now let's talk a little bit about the various regimens and their use to date in patients with chronic kidney disease. Now obviously there's a lot of this information has been generated in regimens that incorporate sofosbuvir, and this study shows that there is some accumulation of sofosbuvir in patients with severe renal dysfunction with a GFR less than 30 mLs per minute, but it's actually some of the key metabolites that appear to accumulate and more, resulting in a much higher exposure in the presence of advanced renal failure. And in turn, obviously that gives rise to concern about toxicity. The good news is, however, that treatment has overall been quite successful. Now, this is a report from Ed Gain last year in which he used a combination of sofosbuvir in reduced dose with ribavirin, again, a reduced dose, in a group of patients, genotype 1 or 3, who had advanced chronic kidney disease. And overall, the sustained virological response rates were a little on the low side compared to what we've seen in the last year or so. But again, this was one of the first reports describing the safe use of sofosbuvir in this population. Now, it wasn't without toxicity, and as you can see, anemia in particular was a concern, but maybe that's undoubtedly a large extent related to the use of ribavirin. This is a report from Miami in which we treated patients again with advanced chronic kidney disease using low-dose sofosbuvir combined with simiprevir. This was a genotype 1 population. Some of them already had advanced liver disease in that they were cirrhotic, and most of these patients were already on renal replacement therapy. But despite these challenges, as you can see, the response rates were overall very good, with an 88% SVR. Now again, small numbers, but very encouraging results. Again, Dave Nelson mentioned this a little earlier today. This is from the Target group, and this is clinicians in the United States reporting their experience with the new oral regimens in a real-world setting. And this was a presentation at EASL earlier this year, in which a number of patients with advanced chronic kidney disease were treated in the practices of the participating centers. And as you can see, these were patients often with cirrhosis. Some of them were liver transplant recipients, and the HCV regimens varied according to the wishes of the treating physician. But again, excellent results. Overall, 88% SVR rate with some decrement in the patients who were already cirrhotic. So again, I can confidently say that at referral centers in the United States, we are now treating a large number of patients with advanced chronic kidney disease. Again, there are issues of toxicity, and anemia appears to be the one that's a particular problem, particularly with the concomitant use of ribavirin. Two other recent presentations from EASL this year. This was looking at full dose of fosfovir with simipravir, and again, response rates were really excellent. 100% in this experience here on the left, and this was just presented at DDWs, and the final results for this study are still pending. But again, a large and accumulating experience suggesting that the use of these newer agents is safe even in the presence of advanced chronic kidney disease. This is another recent presentation. This is the AbbVie regimen. Again, we saw this at EASL this year in a genotype 1 non-cirrhotic population, 2/3 of whom were on hemodialysis. And at the time of the presentation, it appeared that most of these patients had successfully cleared the virus, and were, at least some of them, had achieved an SVR 12. Another presentation from EASL using the Merck regimen in a large number of patients. This is a pan-genotypic regimen. There was no requirement to renally dose these medications. And as you can see, this is a tough population. Again, 75% of them were on hemodialysis. And again, excellent sustained virological response rates. In this report, 99% of patients had a sustained virological response. Again, some toxicity, but interestingly, there appeared to be more toxicity in the placebo group, who were used in the lead-in phase rather than patients on the active regimen. So what I've shown you is a series of generally small reports, with the exception of the Merck protocol, describing excellent sustained virological response rates with acceptable toxicity. Now, again, these patients have been mainly treated by investigators with a lot of experience in managing advanced liver disease and more complicated patients. I think for most of us who are hepatologists, we typically see these patients when they're referred for a possible renal transplant and they're noted to be hepatitis C positive. Now, this is a report from last year, which was presented at the ASLD, using the NHANES data to try and guesstimate the number of patients in the United States who met the criteria for treatment suggested by the ASLD guidelines. And included in this were a large number of patients with chronic kidney disease, perhaps as many as 54,000. Now, one of the problems in trying to treat everybody with hepatitis C with chronic kidney disease is, first of all, the logistical challenges, but secondly, we're dealing with a group of patients who are sick, who have also often, most typically, a lot of comorbidities. And certainly in the United States, 10 to 20% of hemodialysis patients die every year, not of their liver disease, but of their other comorbidities, typically while on chronic hemodialysis. So the major focus of therapy has been in the renal transplant population. And one of the things we're going to have to consider when we decide whether or not to treat somebody with chronic kidney disease is what their options are for renal transplant. Now, as regards the use of hepatitis C positive donors, unequivocally, hepatitis C is transmitted by the use of hep C positive, or organs from hep C positive donors. But there's one reassuring experience from Spain which demonstrated that in 162 patients with hepatitis C who'd received a hepatitis C positive kidney, there was no decrease in patient survival. On univariate analysis, there was a decrease in graft survival which did not persist with multivariate analysis, suggesting the kidneys had been directed to the sicker patient. So this provides reassurance that we can use hepatitis C infected donors in our renal transplant recipients who already have hepatitis C. And this can have a dramatic effect on waiting times. In the US, recipients who would accept a hepatitis C positive kidney waited 469 days for their transplant, compared to 856 days for patients who did not have the option or did not avail of the option of receiving a hepatitis C positive kidney. During this era, however, 2/3 of hepatitis C positive kidneys were discarded in the United States. And this is a recent paper in New England Journal of Medicine which looked at what benefit these discarded organs could have given to potential recipients. And if we look at both, in the case where both kidneys were discarded or one kidney was discarded, you can see we could have added many years of graft and also patient survival to recipients if they'd been given the opportunity to get a hepatitis C positive kidney. And the reason I'm stressing this is that we may be doing some patients a disservice by treating hepatitis C if they're awaiting a renal transplant. So I'm going to conclude by just suggesting some considerations when evaluating individual patients with hepatitis C and renal failure. It's becoming easier to treat these patients, obviously. We're likely to cure the hepatitis C. We may enhance life expectancy, decreasing progressive liver disease, perhaps post-transplant glomerulonephritis, and new onset diabetes after transplant. We'll also avoid issues with immunosuppressive drug interactions with the oral agents if we elect to defer treatment until after renal transplant. And very importantly, we're also decreasing the public health risk of having a hepatitis C infected patient in a dialysis unit if we cure the hepatitis C. Against this argument, however, we now know, based on some of the presentations from today and what's appearing in the literature, that it's becoming easier to treat organ transplant recipients with hepatitis C. And particularly in this setting, if the patient can accept a hepatitis C positive organ, we can then treat their hepatitis C following renal transplant, shortening their time on the waiting list. And obviously we need more experience with this and managing things like the immunosuppressive drugs. But I think for each patient now, there needs to be a discussion, if they are on the renal transplant list, when's the optimal time to treat them. And I would like to conclude by this with this algorithm. So we evaluate a hepatitis C positive patient with chronic kidney disease who's potentially a renal transplant candidate. I think there's still a very important role for liver biopsy, including transjugular pressure measurements in this setting, to assess the severity of the liver disease. If they've mild liver disease, they should probably be encouraged to accept a hep C positive donor. If they've access to a live donor, they should get treated before the renal transplant and then proceed with their live donor. And again, by using hepatitis C positive organs, we can considerably shorten the time a patient waits on, for a renal transplant. So again, I think it's very much on a case-by-case basis, but I think we can make a very strong argument for not treating all renal transplant candidates with hepatitis C if they have mild liver disease. So my conclusions are that treatment is effective and tolerable even in advanced chronic kidney disease. Timing of treatment is based on severity of liver disease and renal transplant options, i.e. whether they have a live donor or not. There are enhanced outcomes for patients and renal graft with effective therapy. And in the interest of time, I didn't address the issue of renal transplant alone and well-compensated cirrhotics. But what's emerging is if a patient has a portal pressure less than 10 millimeters of mercury and does not have varices, they probably do fine with an isolated renal transplant if they have successful treatment of hepatitis C. Thank you very much.
So you've clearly illustrated how the thinking is changing and is evolving as we've got access to DAAs. I've got a practical question. If you do elect to treat a patient pre-transplant on dialysis and you're seeing the RNA become negative, when do you separate that patient from a hemodialysis machine that might be used for hepatitis C positive patients? How do you manage that?
Well, in the United States, there's no mandate to separate, to have dedicated machines for hepatitis C infected patients. I think if dialysis units have the resources, I think they may elect to do that. But right now, they can remain on the same set of machines as before they were treated